Hello everyone, this is Dr. Mohit and today we'll be discussing about Bullous Pemphigoid. Yes, so it is pretty interesting topic and pretty easy one. Yes, so just it is an autoimmune condition, right? So just antibodies are forming against something and the whole mayhem is happening. It is just about the introduction. Okay, so let us begin. Yeah, we will come on to this. But first the definition. What's the definition about it? So first of all, it is an autoimmune condition. Yes, this is an autoimmune condition. Let us just write with that. Autoimmune Okay, so this is an autoimmune subepidermal blistering disease. Yes, so and the bullas are formed between what and what? Epidermis and the dermis. In a while, we'll see the exact location. Yes, where the antibodies are formed. Okay, all right. So antibodies. Okay, so antibodies are again the subepidermal connections. Okay, so what are these connections? We'll see. Okay, and this is a pretty rare disorder. Yes, it's about 60 years of age we would see, and the prevalence is almost equal in male and female. Okay, and we'll come to the drug causing part. Let us just go on to this. Okay, so we talk about this extensively in our detailed series, right? But for now, I'll just make you focus on the Bullous Pemphigoid. Yes, so what is this? This is, we have the epidermis, yes, and we have the dermis. Yes, as you can remember our diagram, we have the epidermis, dermis, and the tissue below it. Yes, okay. So what is happening is, so this is a diagram of between the two layers. So we have the epidermis and we have the dermis. Yes, and the connective tissue between. So what is holding these two things? Yes, that is the diagram for this. Simple. If you know this much, it is well enough, nothing to be more bogged down about. Yes, over here, as you can see, all these spider-like things, spider web-like things, what is doing is they're trying to hold something. Something is being holding on to something. Simple, very simple thing, right? So let's just focus on this one thing right here. If you see the red structure, yes, the red structure, these are the hemidesmosomes, and inside the hemidesmosomes, this is this BP1 antigen. Yes, so right here, if you just focus on, this is the BP1 antigen which is inside the hemidesmosome. Simple. Just get one point at a time and the whole topic will be very easy for you. Okay, this is BP1, done with that. Where does this Bullous Pemphigoid antigen number 1 or BP230 lies? The answer is inside the hemidesmosome. Okay, if you see this diagram very clearly, I have drawn the orange thing which is there inside the red. It is not outside, but if you look closely, the blue lines are outside. So the second part, that is the BP2 antigen, also called as 180. Yes, BP180. This is the one which is outside. Okay. So what is happening is, in our topic of discussion, there are antibodies formed against these two things, that is BP1 and BP2, that is 230 and 180. Okay. So now you have the orientations very crystal clear. Okay. Fine. All right, so very clear about these things. Okay, if you want to hear more about all this thing, right? So we went and each and everything, you can see what is written over here. It was explained very detailedly, but for this topic we only need this much. Okay, all right, going on to the drugs. Drugs which can cause Bullous Pemphigoid, something which can elicit, is these are the furosemides, NSAIDs, ACE inhibitors, and antibiotics. Pretty vague finding, but yes, they have some correlations to it. Okay, how about the presentation? You see the presentations, just think, okay, if something is happening because of the antibodies, do you think it will be immediately? Do you think? It is impossible. It is impossible to have anything like this immediately, because it is not like a reaction, something is happening to the body is not really accepting it, it is making some antibodies, and because of that there is some reaction. Do you think this whole story happens in few minutes or few hours? Impossible, right? So there will be some prodromal symptoms, okay, and there will be some findings initially, and in the later part we would find all these bullas. You see, these non-flaccid ones in the later part we'll find, but initially there will be some prodromal symptoms, okay. All right, even though the prodromal symptoms in this, yes, are not very specific, but they are there, okay. So we have prodromal period which is there, okay. Prodromal period, okay, it goes on for weeks, yes, and after that we have these tense bullas, which they appear, okay. And for this one, we just come on to this point, that is, these are negative for 𝗏𝗏𝗏𝗏 sign. What is this 𝗏𝗏𝗏𝗏 sign? On a bulla, if we apply some tangential pressure, and if the epidermis, right, it just slides off, that is a positive 𝗏𝗏𝗏𝗏 sign. Simple as that, okay. And what are the prodromal symptoms? Pruritic and plague-like lesions will be formed, okay. All right, the oral lesions which are there, which are very rare, but we have seen in Pemphigus vulgaris, okay. Pemphigus vulgaris we have seen. So we spoke about Pemphigus so much, in a very extensive detail we spoke about Pemphigus vulgaris, and vulgaris means the most common type, yes. So in that we have this oral lesions, but in this we don't have it, okay. It's very rare to find some oral lesions, okay. What is the patient predisposed to? Because the skin, right, there are blisters forming, yes, so the patient is prone to having secondary bacterial infections, yes, and fluid loss, the patient is suspected to have fluid loss, yes, and also decreased daily activity is definitely, somebody who is having something like this, we don't, it is pretty obvious, right, that the person, his or her movements would be very restricted, okay. So those are all about the complications. So how would we go about the treatment? Yes, so first of all, the mainstay would be, we would stop the offending agent in case it is a drug or any other thing. The second part would be, we would control the immunity of the patient. We don't want the immunity to be very soaring high powerly, right? We would want to just decrease the power of the person's immunity. So how would we do it? We would give high potency topical corticosteroid just to apply, and we would give systemic as well. Yes, the second line would be systemic steroids would be given to the patient, okay, 𝗶𝗏𝗏𝗏, and we would give intravenous immunoglobulins so that we could directly go and kill those antibodies. Yes, if it is possible, definitely we'll do, but this is not the first line treatment, okay. First line is definitely, we just give the topical drug and we give the systemic drug, and then followed by the IVIG, okay, the intravenous immunoglobulins, okay. And one last point over here is patients, right? Patients, we don't encourage the patients to keep fidgeting with the bullas, yes, and not trying to break the blisters, because if the blisters are broken, the epidermis is broken and the patient is exposed to secondary infections. Yes, there is increased risk of infections in the patient, okay. All right, so that was all about Bullous Pemphigoid. Yes, so I hope you guys like it, and a pretty short topic, yes, but you should be knowing what are the antibodies, what structure of the antibodies are against, yes. So if you know a few things, we could have a better grip on this topic. Yes, so thank you so much for listening.